Joining, please make sure you're all muted. We're going to be hearing the presentation by Dr. Jeffrey Kahn. It will be moderated by Dr. Mark Meiches. And let me turn it over to Mark, who can start it off.
In the middle. Yeah.
Everybody muted? Okay. Thank you very much, Phil. And we're going to get a few quick logistical things out of the way early and then move on to Jeff. The first thing is to thank Phil and thank Hazak for this presentation, COVID-19 impact on seniors. And we're going to specifically try to address some matters that apply to this group of people. A lot of you have sent in some questions already, and we've incorporated those in the talks. If you have additional questions, please go to your chat function and send them directly to me, and I will take them down during the talk, and hopefully we'll have some time to ask Jeff those questions. We ask you not to send them to the whole group, just again, send them to me and I can sort of broker those and add the ones that are new to our text. As with everything medical, the first thing we have is a disclaimer. A group of seniors is a unique population. If Jeff were giving this talk to a bunch of 10-year-olds or a bunch of 20-year-olds, they'd all pretty much be in the same health level of health and have the same recommendations. You're a different group. Some of you are healthy, don't take any medicines. Some of you might have heart disease or lung disease, diabetes, maybe cancer survivors, and each of you may be at a different level of risk than the other. So what Jeff's going to talk about today is sort of the general recommendations, general thoughts, but each of you as individuals need to talk to your doctor, certainly if you have any medical conditions, to see what's exactly right for you. Some of you may need to be a little more rigid in what you're doing in terms of restrictions than others. The top 3 risk factors they found with COVID in elderly adults is heart disease, lung disease, and diabetes, and that may cover a lot of people. So whatever Jeff's saying is a generalization, but it doesn't apply to each of you individually. So be sure just to talk to your doctor and make sure you're doing what you need to do. I'm going to go over real quickly what we're going to talk about tonight, and then we'll get started. Jeff's going to give us a quick review of the status of COVID outbreak in our community and in general. And then we're going to address a few topics that are sort of new to us in the world of COVID, namely flu season and what are the implications of flu season. We're going to talk about the fact that kids are going back to school. How should that maybe change your lives if some of those kids are somebody you're going to be in contact with if you're seeing your grandchildren or living with them. We're going to talk about an update on the vaccine. And the vaccine is something we hear a lot in the news, but the bottom line is we don't have one right now. And so while Jeff will address what he can, I ask you not to ask too many specific questions because we simply don't know. He'll tell you everything we can about what we're expecting, what we're hoping for. But in terms of some of the questions we've already received, when can I go on a cruise after I get the vaccine? That's all speculation at this point. So we'll try to give you the best information we can, but remember, there isn't a whole lot of information yet. If time permits, we're going to talk about the special implications of the senior facilities that some of your spouses or parents may live in, as does mine. That's sort of a unique world that applies specifically to seniors, but it's a unique set of problems and considerations. And finally, again, time permitting, we'll ask some general questions. So with no further ado, I want to introduce and thank Dr. Jeffrey Kahn, who's the Chief of Pediatric Infectious Disease at UT Southwestern. Jeff?
Thank you, Mark. And thank you, Phil, for the invitation. And I'm going to go ahead and get started. As Mark mentioned, I'm a pediatrician, so I don't typically have conversations with people like this unless it's their grandchildren or children. So, but nonetheless, I want to give everybody an update on what's going on with COVID. So now I'm going to try to share my screen, and everybody should see a PowerPoint.
We're good.
All right, is that working?
Yes.
Okay, so let's go ahead and get started. So I'm taking the data I'm going to be showing you right now is actually taken from 5 different sources, and some of you may be familiar with these sources, or one or more of them. Some of them have distinct advantages and disadvantages, and we'll go through them very quickly. And I don't know whether there's an opportunity. I could certainly share these slides with anybody who wants them, so maybe we'll work on something like that at the end. So I think why don't we go ahead and get started. So this is the Johns Hopkins dashboard, and they've been doing this really since the beginning of the epidemic. And I do have a screenshot what this web page looked like back on April 12th, 2020. And you can see at that point there were about 1.8 million cases worldwide, and the dots represented where the cases were. And you can see there are sort of the size of the dot actually is corresponding to how many infections they were having. So this is what it looked like on April 12th. And today, I just downloaded this today, earlier this morning actually, and you see we're up to 27 million cases. So if you do the math, in 4 months, we've gone up 15-fold, 15 times as many cases. The neat thing about this particular dashboard is that you could zoom in, and here is the data for the United States. And again, this is data that was updated just yesterday, September 7th. And the more purple the area is, there's more activity of the virus, and we'll talk a little bit more about that. One of the shortcomings, perhaps, of this particular website is that they just show you cumulative number of cases. And that doesn't really help as far as how are things right now compared to where they were a week ago or a month ago. So there is another website that I've been using, and for all of you who are out there who are interested in this kind of thing, this is really the website that I recommend. And it's if you just type in pandemics explained, you get to this website, which is sponsored by Harvard and Brown. And if you look in the lower left-hand corner, there are different colors, different grading systems for how active the epidemic is. And this is based on a county-wide level. So every one of those little squares or areas that are shown in the map are actually a county. And you could zoom in, of course, to Texas, and here it is. And again, the color coding is explained on the website. I'm going to go back one slide and see that the green is on track for containment. The yellow is community spread. The orange is accelerated spread, and of course, red is tipping point. We don't want to be in red, but you can see there are several counties in the United States as of today are red, and the same is true in Texas. And what's nice about this particular website is you can mouse over any county like this, and here it is, Dallas County. Dallas County is now orange. It was just a few weeks ago where Dallas County was actually in the red, meaning that it seems like the amount of virus circulation here in Dallas County has slowed down. And you can see these numbers are daily new cases per 100,000 people, and this is a 7-day average. So this is quite a dynamic. And of course, you could do the same for Collin County, which is here, which is actually yellow. And there's actually less virus circulating in Collin County compared to Dallas County. So that's what we have here. Texas, also, the state of Texas also has a dashboard, and here it is. I'm showing an example of that. What's nice about the Dallas website is, again, you can go to look at the positivity rate. And I'll be talking a lot more about positivity rate in a few minutes, but you can see on this graph here, this starts at really the end of March. And then you can see during May, there was very little, low circulation of the virus as far as positivity rate. Then we had a peak at the end of June and July. That seemed to settle down. There was another big peak here. Maybe we could talk about that a little later. This may have to do with reporting, not necessarily new cases. And then you can see the trends are going downward. So this is a very good trend here. Although we're still pretty high, this is a pretty good trend. And again, you can go by county. And again, I'm doing Dallas County, and looks like the trends are headed downward. This is cases in Dallas. This is death rate and deaths in Dallas. And the same is true for Collin County. Although the numbers are much smaller, it's a little bit more difficult to make sense of this graph. Dallas County Health Department, Health and Human Services, has their own dashboard. And I'm going to go through this very, very quickly again. So here is this graph that was produced in their latest report, which was published today. And again, I think what I really want everybody to focus on is this dark line, this dark black line that goes to the graph. And that is a 7-day rolling average of confirmed positive cases by date collection. So you can see this is overall the number of cases. And sure enough, after May, and there was probably a lot of activity. I should pause for a moment here and say that in May, 2 things happened. One, there was a relaxation of social distancing restrictions by the government. And 2 is that there was probably a lot of intermingling, groups getting together at the Memorial Day weekend here. And then sure enough, we saw this big spike here at the end of June and July. And what's promising, at least to me, is that the trend lines are going down. And this is Dallas County data. Here is another way to look at sort of the same data. Again, I want everybody to focus on the red line here. This is the percent positives. So in other words, how many tests are obtained and what percentage are actually positive for COVID. And you can see that it peaked again at the end of June, and there's a nice steady decline until we get to the beginning of September. Now, just to put this into context, we're just about at 10% positives. New York is now boasting, that's my home state, New York is now boasting they've gone 30 days with the percent positive rate being less than 1%. So we certainly have a long way to go, but we're headed in the right direction. Okay, the last thing I'm going to mention is some of the modeling, and this is done at my home institution, UT Southwestern. And again, if you just Google UT Southwestern and the modeling system, you'll get this. And I just want to show you a few bits of data. Here is what happened. This is what is presented on the Dallas County website, excuse me, on the UT Southwestern website. And you can see this is a time curve here. So this is April 1st, May 1st, June, July, and August 1st. And this graph is really looking at how fast the numbers are accelerating. So in this graph, the higher numbers are bad, the lower numbers are good. And we really want to see these curves go down. As you can see here on the right, the epidemic grows if it's above this line, and the epidemic declines if it's below this line. And you can see that here it is in Memorial Day, we had this big peak, and then the mask order was put in place by the governor, and you can see there's been a decline. It's a little bit bumpy here. Now, of course, kids are headed back to school, so we don't know where this is going to go, but we'll talk a little bit about that in a moment. This, I think, is a very interesting graph as well. There are many ways to monitor the pandemic. One, of course, is to just measure or document how many people are actually testing positive. And that's all the data I've shown you up to now is based on positive tests and the percentage of positive tests. This is looking at it somewhat differently. This is looking at the percent of daily doctor visits for COVID-like symptoms. And when I say COVID-like symptoms, we're talking about fever, cough, headache, difficulty breathing, loss of sense of smell or taste. What helped out during this period, and it goes from May 1st on the left-hand side to the end of August, is that there was very little influenza circulating at the time, and actually very little other respiratory viruses. So this data probably all represents COVID. And you can see if you just look at symptoms, not relying on tests whatsoever, if you just look on how many people or what percentage of people are going to the doctor with COVID-like symptoms, you can see, interestingly enough, in June, we had this big uptick in all the 4 countings, that this is Dallas, Tarrant, Kahn, and Denton. It peaked somewhere at the beginning of July, very much like what I just showed you in looking at percent positives. And then there's been this sort of gradual decline of numbers here as we get to the end of August, and here are the percentages. So this is another way to look at the pandemic, and I think it's certainly consistent with the data that we've been seeing on a local level, the data that's been collected by the county and the state, and also the data that's represented in the Harvard and Brown dashboard. So I think we can say that the trends are all headed in the right direction, certainly for the counties that are listed here. But we certainly still have a long way to go before we get to a level where I think we can feel comfortable about opening up a little bit more than we have now. So with that, I'm going to stop sharing. And now I guess we'll go to questions. Mark.
Actually, let's, at this point, we don't have any questions about the general things. Let's move on to the flu, if we could, the upcoming flu season, influenza season.
Mm-hmm. Okay, so this is going to be an interesting flu season. Influenza typically starts in Texas in late November or December. Sometimes it's in February. But it's going to be very difficult to distinguish on clinical grounds whether a patient or an individual has COVID or influenza because the symptoms overlap so much. And it's going to be particularly challenging for healthcare providers to figure this out. Fortunately, we have a vaccine against influenza and we have medicines that work against influenza. So that's one advantage. We don't have those those resources for COVID. We'll talk about that maybe in a little bit, but it's very, very important to get your flu vaccine this year. The flu vaccine should become available shortly. Ideally, you want to take it 6 weeks or so before the start of the season. That's always very difficult to predict. As I mentioned a moment ago, it could be in November, it could be as late as February. So I'd say that right now, in the next couple of weeks, start considering getting the flu vaccine. What we don't know, what we haven't had experience with right now, is what happens if you get COVID followed by flu, or maybe more importantly, flu followed by COVID. These are both respiratory viruses, and there is a chance that having these two infections at the same time or within a very short period of time can actually lead to a lot worse disease than having them individually. We don't know that yet. So nonetheless, I would certainly strongly recommend everybody get a flu vaccine. Now, the flu epidemics typically start in the southern hemisphere. So in places, well, in Australia right now, they're actually just headed to the end of their winter season. And there are a couple of interesting things that have come out of Australia. One is it seems that there's a pretty mild flu season. And the reason probably is because everybody's wearing a mask. So masks really, really work, and they work really well. And they work really well not only against COVID, but against influenza. So that's one thing that's really quite remarkable, at least the preliminary data coming out of Australia. Now, there's a second reason perhaps why there's so little flu in Australia, and that is, of course, they've closed the schools. We know that schools are places where there's a lot of spread of influenza and potentially of COVID. So this is going to be a new time for all of us, and I would certainly strongly recommend that people get their flu vaccinations. Now, flu vaccinations, the track record for flu vaccinations, some years are better than others. There's a new vaccine that comes out every year. Of course, we all know that. We have to get re-immunized. The characteristics of the vaccine are based on some projections about what the next year's flu will look like. Sometimes it's a really good match. Sometimes it's not such a good match. But even in years where it's not such a good match, it does provide protection, sometimes against infection, but sometimes against severe disease. So influenza vaccine can actually make a potentially severe influenza disease much more mild. So I think that's the word on the street as far as getting immunized against influenza.
We did have a few questions, and if you can clarify, a few people were asking, is there any cross coverage of a flu shot for COVID and vice versa? And obviously we don't know anything about the COVID vaccine yet, but is there any concern that they may affect each other once we do have a COVID vaccine?
So let me first state that it's unlikely, I should say, that the influenza vaccine is not going to give you any protection against COVID. These are two different types of viruses. On a molecular level, they look very different. So you're not going to get any protection from COVID by getting a flu vaccine. But of course, you get all the benefits of the protection against influenza, against flu. So definitely get the flu vaccine. I know that there's been a lot of talk about COVID vaccines right now. There are at least 7 that are really deep into phase 1, 2, or some actually approaching phase 3 clinical trials. Some of the vaccine candidates are based on the same strategy which we've used for other viruses, like influenza, like measles, polio. Some vaccines that are being tried right now are on completely new platforms. And some of them that have been studied so far have been promising in the sense that they tend to produce an immune response. Now, whether that immune response is protective, we don't really know yet. And the data that's coming out so far is based on some very small populations. So we're going to have to wait for some very big studies. Now, if you think about if you want to study a COVID vaccine, there are a couple of steps, of course. You have to identify people who are going to be your test subjects. And you know what age groups and what parameters you want to look at. That's a big question. Then you have to give them the vaccine, see if they have an immune response to the vaccine. But the most important question, of course, is whether they're protected against infection. And several months ago, there was thought that, well, let's start this trial in the New York City area because there was a lot of virus and we can easily find people to step up and roll up their sleeves and get immunized. And since there's so much virus circulating, it's likely that people who got the vaccine or a placebo will come in to encounter the virus, and then we'll easily tell what's the infection rate between the people who got the experimental vaccine and the people who got the placebo. Well, that was a great plan, but now there's very little COVID in New York. So now it's very difficult to do that trial in New York because there are very few new infections. So one would think that maybe here in Texas is a good place to do it, and that's true. But mind you, there's a big process to gear this up, and in 4 or 6 weeks, we may be at New York levels, we hope so. But in that regard, it's going to be very difficult to test the vaccine. So I don't see a vaccine becoming available anytime soon because it has to go through these rigorous clinical trials.
We do have a number of questions regarding the vaccine, and even though they're sort of theoretical, hopefully you'll have some insight.
Therapeutic, the branch of medicine concerned
Hello?
with the treatment of disease
Yeah,
and the action of remedial agents.
Can somebody, if somebody's got a mute button, thank you. Before we talk a little more about the vaccine, can you share any insight into the risk of contacting of someone acquiring COVID or becoming symptomatic if they've already had it before? What are we finding so far that people have had it? Can they reinfect, or is that proving to be preventative?
So
Do we not know?
right. So there are a couple of storylines here that are coming out in the media, and some of them not quite as accurate as they should be. So we do know that people who get COVID and recover may shed virus from their nose for quite some time, or at least the genetic material of the virus. We don't know how infectious that virus is. Our tests for COVID, particularly the molecular-based tests, are really, really good and really sensitive. So we know that somebody who's got COVID, who's recovered, I should say, can test positive for COVID for weeks or months. And that's why the CDC is moving away from testing after somebody's recovered, because they'll probably have some virus. So that's one aspect. Now the real question is, can you get reinfected? Well, if you're still shedding virus a month later and they test you and you're positive, was that the first infection or is that a new infection? There are a couple of articles that have come out, some recently, that have shown that people who've gotten infected can get infected again. But the caveat here is that in these small number of cases, the people who have a documented second infection, in other words, the strain of the virus in the first infection is different from the strain of the virus in the second infection, their second infection actually is very mild or asymptomatic. So, I think when we talk about repeat infections, what most people are thinking about is symptomatic disease. And I think that that's probably quite unusual. Now, we don't know how long natural immunity to COVID lasts. The epidemic's only been going on for 8 months or so, and the virus has only been in this country for about 6 months. So as we move forward, we'll have more information. For example, next year, if things with COVID finally quiet down, somebody infected this year, can they get reinfected next year? How long lasting is the immunity is the question. We don't know that answer. It seems to be at least a few months because that's the length of time that we've been studying this. So more to follow on that. I'm less concerned about repeat infection right now than I am about, of course, primary infection. But I don't think reinfection is actually going to represent a large burden of disease.
I don't want to dwell on it, but you mentioned it. Can you explain a little bit about different strains? It's actually not one strain because that may be confusing to people.
Yeah. So thank you for pointing that out, Mark. We're actually right now we have the ability to look at the entire genetics of the virus, and there are some very, very subtle differences between some of the strains that are circulating. They're all the same strain of COVID, but they have very, very small differences. So much so that there seems to be two entries of the virus into the United States. The virus that was originally identified in China, in Wuhan, and some of the virus that was circulating in Europe, that also came to the United States. And if you recall, there was a big outbreak in Italy. They probably had the biggest outbreak first in Europe, but that virus was slightly different, maybe 1% different from the virus that came in from Wuhan, China. As far as the clinical disease is concerned, they're identical. Their ability to spread through the population, identical. But their fingerprints, if you will, are just slightly different. Different enough, though, that we can tell the difference between a virus that came in from China and a virus that came into Italy. Now, mind you, these viruses are continuing to evolve. So this is really, really very helpful and when we're trying to really specifically track the virus. And on an individual basis or on a county-wide basis, it probably doesn't matter all that much because we have a lot of virus circulating here. But the fact that we can tag some of these viruses and watch them circulate through a population gives us a lot of information. And that was how we were able to tell that this one particular individual actually had two different viruses, albeit very, very similar, but they were distinct.
We got a number of questions about a certain issue regarding the approval of a vaccine. And I think a lot of our seniors are feeling sort of a catch-22 here. We're hearing a lot in the media that with the development of vaccine, they may be shortening the phase 3 trials if they're getting good enough answers to put out a vaccine. And yet, by the same token, we're hearing that the first people to get the vaccine will be healthcare providers and basically seniors for people who are at risk. And so I think a lot of our seniors are saying, well, they're telling us they're going to shorten the preparations and the safety of the vaccine, and yet we're the first ones to get it. So people are asking, should we hold off, even though we're really the ones who should be the priority ones to get it? How long should we wait when it is out? Because maybe the testing isn't what it would be if we weren't so pressed to get something out there.
Yeah, so maybe this is a topic for a talk at some later date, because we really don't have any publicly available data except for very small phase 2 trials, phase 1 and phase 2 trials that really got the vaccine investigations going. So, we're all hearing these rumors, and we certainly want a vaccine to be properly vetted and tested and studied to make sure that it's safe and effective. And we could talk about effectiveness in a minute. So right now, with 8 or 9 different vaccine candidates that are entering really robust clinical trials, it's very, very difficult to make any projections or recommendations as how we should use these vaccines. Making a new vaccine usually takes many years. We don't have that luxury now, but we do have the luxury of advances in molecular biology. So that's why we have these 9 candidates, at least 9. By the way, if you go to the NIH website, there are over 100 vaccine candidates that are still maybe in the research part of development, the laboratory part of development. So we're gonna have to look at each vaccine candidate individually and go from there, determine how we use these vaccines. So for example, if there's a vaccine candidate that's only tested in healthy 20-year-olds, well, maybe that's not the vaccine candidate that we want to give to other populations for whatever reason, because they haven't been tested in other populations. On the other hand, some of these vaccine candidates, at least in the preliminary studies, are quite promising as far as the immune response that's developed. Whether that's protective or not is a different story. So we really don't know. And I think that once the trials and the data becomes available, we'll have a better idea. And I think that there was a blurb in the paper today that the FDA and the major drug manufacturers, at least the ones that are involved in producing a COVID vaccine, have promised that they'll do this with the utmost integrity and make their data transparent and available. So we're just gonna have to wait for that. We never had a vaccine developed this quickly for any disease. So there's a lot of uncharted territory. That's not to say that we won't come up with a great vaccine. There may be a great vaccine for this, but we certainly don't know, and we're just gonna have to wait until we see the data.
Another thing that people are seeing and asking a lot about is some information in the media that the FDA criteria for full approval of a vaccine is one that would reduce the rate of symptomatic COVID-19 by 50%, assuming, again, there's no harm to patients. So, and people are asking, is 50% good? Is that standard for vaccines? Why 50%? That doesn't seem a lot, I know, to people, but can you speak to the validity of the 50% and the fact that it will hopefully get better too with additional other vaccines, or progress in that individual vaccine?
Right. So there are many ways to measure a vaccine success. Right now, what we know is that if you give a vaccine to an individual and you take their blood, their bodies responded to it. But that really doesn't tell you whether they're protected against infection or protected against disease, and those are two different things. So the question is, how do you measure a vaccine success? Well, with polio and measles and mumps and those types of viruses, we basically eliminated the virus. I would suspect that nobody on this call has seen a recent case of measles. I would say that maybe some of you, sorry about that. Maybe some of you have seen a case of polio, but we haven't seen a case of polio. There have been reported cases of polio, but that's very, very rare. So that is an example of a vaccine that really provides what we call sterilizing immunity. Once you get the vaccine, you don't get the disease. You don't get infected, nothing. You're protected. Another way of thinking about vaccine effectiveness would be that it lessens the severity of infection or lessens the severity of illness. So if the vaccine can prevent you from getting so sick that you need to go to the hospital and you had to go, or they're going to put you in the ICU, and you're only going to get mild symptoms, a mild cold, then some people would consider that a success. So it didn't prevent you from getting infected. You did get infected, but you only had mild disease. And to a certain extent, a lot of the influenza vaccines that have been given year after year after year, their efficacy has been, sometimes in a good year, 70%, in a bad year, 30%. But if it protects you against severe infection, that's a big plus for a vaccine. Now, we don't know whether these vaccines, you'll need a booster shot to get the full immunological benefit from the vaccine. We don't know whether you'll need a booster shot a year from now. We don't know whether you'll have to take a vaccine from one type of vaccine and another type of vaccine. We know none of this right now. But the 50% mark, well, it's better than zero, right? And if I were to tell everybody, well, this decreases your chance by 50% of getting infected, I think a lot of people would roll up and it's safe. I think a lot of people would roll up their sleeves. If I said, this is a 50% chance of making your disease a lot less severe, that's a win too. So I think we have to be thoughtful when we start thinking about what is the endpoint here. And if the endpoint is just really decreasing the severity of the burden of disease, then either one of those options for a vaccine would be a success. So I think 50% may be pretty good. It's better than we have now.
And I think it's important to say too, if we do get 50%, that doesn't mean the research is going to stop. We may have another company that now offers 60 and then 80. And it, as you say, it's so fast, but in time, we may get to where we want to be at the 95+ level.
That's right. That's right. And there are many examples of this. I've mentioned, measles before. And we know that if you get a booster shot later in life, it really enhances your immunity. So it could very well be we need a second dose at some point in time. But even something as good as 50%, that may be good. That will be. And good.
Something else you alluded to earlier, there are years with the flu shot, for instance, they find out isn't as wonderful. Maybe it's only 30 or 40 or 50%. But when you look at the population, that still saves thousands of lives. It may not be optimal, but it's a big difference. And we always will be shooting for more.
That's right. That's absolutely true. And we're so tuned into what's going on with COVID now, and I showed you the graphs. What I didn't show you was a lot of the ICU data and the mortalities due to COVID. But if we can start crunching those numbers smaller, then that's a big benefit. Let me just pause for a second and mention one other thing. If you look at the United States now, and how many infections we have, and do some rough calculations right now, even if you think that for every one COVID case, there are probably 10 others that haven't been diagnosed or had mild disease or asymptomatic disease. But let's say that the number of COVID infected individuals in the United States is actually 10 times the amounts that are being reported now. that still only represents about 10% of the population. So 90% of the people in this country are still susceptible to this virus. And, the social distancing measures are working, but we still have the vast majority of people out there walking the streets on this call are still susceptible to the virus. So a vaccine that protects, that gives you 50% effectiveness, that's a big, big benefit. So we're all keeping our eyes on the vaccine. Certainly, we hope it doesn't become politicized. It's not put out too early, and we hope that it's safe, and so on and so forth. But this is what we're up against. I think many of you will remember back in 1976, there was thought there was going to be a swine flu outbreak, and the president at the time, Gerald Ford, really pushed for a swine flu vaccine. Well, there was no epidemic at that point, but a lot of people got sick from the vaccine. So you got to be really careful when it comes to vaccines, because there could be some bad outcomes from vaccines.
So let's move on to another subject. There's something new that's going to be going on in our world that we haven't encountered during COVID, and that is our students are going back to school, both colleges and grade schools, high schools. So talk about two different things for me, if you would. One is the practical implications from some of our seniors. If they're going to be around their grandchildren or kids that are going to be at increased risk potentially, should they be taking extra precautions? Should they be staying away from the kids for a while? Should we wait and see before they, know what the real rates are going to be among our children? And then besides the practical point of view, you showed us a lot of graphs, and I know this is speculation, but especially as a pediatrician, where it's a population that now will be really hitting your group, what are sort of the models that anticipate where that graph's going to go? We expect it to go up somewhat, but what's your understanding of the concerns or the realities of what may be coming?
So I think by now we should all accept the fact that children do get infected. For some reason, children tend to get less severe disease than adults. It seems to be age-related. This is a little bit different from influenza. Influenza is typically causes severe disease in very young children and the elderly. COVID is not the case. It seems that children are, for the most part, pretty protected against severe disease, probably about tenfold protected against severe disease. But we do know that they get infected, children get infected. We do know that they carry a lot of virus in their nose when they're infected, and they can spread the virus to other individuals. The greatest chance of anybody getting COVID, and this is true for other respiratory viruses, is that if you have a household contact who has COVID, the virus spreads very readily in the house, in the home. So the important message here is that we're sending kids to school. Hopefully they'll be wearing masks, and there'll be measures in place at the school to slow things down. But the virus is going to find its way into schools, and the kids are going to bring home the virus. And there are now a number of published studies looking at this. One from Israel, as a matter of fact. They send their kids back to school. I don't think they had a lot of the measures that we're thinking about, masks, social distancing, so on and so forth. But they had to close down the schools. But the one interesting thing about that study was that as you went up in grade, the transmission of the virus decreased dramatically. In other words, there was a lot of spread in the middle school, the kids who were in the middle grades. But as you got up to 11th to 12th grade, very little spread. Probably because the kids were mature enough to understand wearing a mask is important, social distancing is important, wash your hands is important. But nonetheless, getting back to the issues here, the virus is going to find its way into schools. If you have family members who are, young children going back to school, I would be careful. I would be careful about getting exposed to them until we have a better idea of what the landscape is going to look like. We know that the virus is going to spread in schools. To what extent, we don't know. And I think the real challenge here is that the children can be asymptomatic and still spread the virus. So it's not as if it would be one thing if it was only symptomatic children who were spreading the virus. They'd be easy to identify, but that's not the case here. So be very, very cautious if you're sending your kids back to school. And if you fall into one of the high-risk groups, of being exposed to them, because they can't transmit the disease without being symptomatic.
This is a little bit of a loaded question, but for those seniors you just advised to be cautious, are we saying 4 weeks, 6 weeks before we, when will we have an idea what the reality is for them?
It could be 4 weeks, it could be 6 weeks, it may be longer. We're doing this experiment throughout the country right now. And as I mentioned, in New York, they're opening up the schools at a very low rate. Will there be a second peak? We don't know. This is a moving target. And, the way that we're going to assess the situation is obviously with robust testing. But right now, I can't give a timeline to when we can say, all right, we can let down our guard a little bit. We're way far from that.
I think that's very helpful to know those that may be around their kids can, consider if they need to take some of their actions or get some distance from them.
Right.
I think that's all. A few people asked also, obviously parents are very worried about their children going to school for the sake of the children, and especially those who are teachers and working in the schools are very concerned. And I know that's a very tough issue because some school districts are requiring kids to come, some are not, some are requiring teachers to come. So can you speak to any insight you have as to, your perception of how people can allay those fears if they have any, and especially both as teachers, some people have children who are teachers, and then for the kids themselves.
Right. And, it's all these concepts that we've been hearing about for months now that are decades, if not centuries old, about, doing the smart things, wearing a mask, hand sanitizing, social distancing. Now, of course, in the schools, that becomes a bit more challenging. I know there are a lot of schools that have been trying to restrict the intermingling of the students. And I think that's a very important component of this. So therefore, that any teacher or any educator who's in the school will only be exposed to a subset of the children. One of the things that I've been recommending to both parents and teachers and such is, what is the plan if there's an outbreak? How is the school going to deal with that? What's the damage control? What's plan B, if you will? And I think if the schools do this right and keep each classroom or grade, if you will, separated from the other grades, then they could control the spread of the virus easier than if they let everybody intermingle in the lunchroom, for example. But this is going to be a challenge. This is going to be a big challenge. And, we have to get on top of this with testing and monitoring. And, this is a lot of data that we don't have right now. So yes, this is uncharted territory.
Okay, let's move on to another topic. It's one that's actually been hot at the beginning of this, but it's something that still affects a lot of our population, and that's regarding senior facilities, assisted living, nursing homes. Those people are at special risk because of where they are, and I know a lot of people have been isolated from them, and it's hard not to see them. And at the same time, we realize that they're at tremendous risk, and there's really nothing we can do about that as individuals. So can you share any insight you have into that?
Well, we know that there have been some pretty big outbreaks in nursing facilities and chronic care facilities. And as you mentioned, Mark, these patients are typically at high risk. That's why they're in these facilities. And I know how difficult it must be to not be able to visit loved ones. But these facilities, thankfully, have taken this very seriously, and they limit visitors, they limit interactions, and so on and so forth. And we have to be that stringent with our control protocols and procedures, so the virus doesn't get into these facilities. These are a very, very prone population. And we do know that once the virus gets in, it can spread quite rapidly. And I think the other thing to note about the virus, I haven't mentioned this yet, is that one of the things that, again, makes this virus, an additional feature that makes this virus so challenging is that people can actually shed virus before they're symptomatic. So just telling people to stay home when they're sick, well, that's going to prevent some virus from circulating, but it's not going to prevent, the person who feels well going into work who doesn't know that in a day or two they're going to feel quite ill. So this is another big challenge, and that applies to every one of us. That we may be shedding virus before we're symptomatic. We may infect individuals around us before we even know that we're sick.
we're down to basically just a bunch of questions that people have asked, and they cover some broad areas, so I'll kind of pack them into little groups.
Okay.
A lot of people are asking, in terms of things like eating out, going to Sam's and all that, would your recommendation be to have those places deliver it, or pick it up, or feel free to eat outside and go in yourself with a mask? People want to know what's the safest of those options if you are going to engage in some Costco purchasing or some restaurant food.
Well, if you take this to the extreme, the safest thing to do is to isolate yourself from everybody else. I mean, obviously that's not practical, but if you lived in a cave and weren't exposed to another individual, then you're not going to get the virus. But obviously that's not we can't do that. Eating facilities, they tend to make me a little worried because obviously you can't eat with a mask on, and I would be very reluctant to use that as my first venture out. I mean, I think getting takeout or, going to the grocery store, I think with the proper mask and social distancing, I think the grocery stores have done a nice job. I'm comfortable with that. I think Costco's done a nice job. But if you could have somebody, if you happen to fall in the high risk group, and if you can have somebody do this for you, then I would certainly recommend that. We do know that these measures work quite well. So just be mindful of this. People tend to get fixated on, well, it was that particular item in the grocery store touched by somebody beforehand who may have been infected. Well, that may be true, but that risk is probably much lower than coming into contact with somebody who may be sitting 6 feet away who's eating and coughing or sneezing. That's where I get really worried about things. So I think on the first level of things not to do, it would be eating in public, and even if it's outside, I think I still feel somewhat uncomfortable with that. Of course, it depends on the setting and such, but that wouldn't be the first thing I would recommend for people. I think takeout is fine, and going shopping and doing your cooking at home.
So the preparation of food at the restaurant isn't your concern so much as the eating it in the environment of other people. That's right.
I mean, we take a lot of assumptions. We make a lot of assumptions here, actually, that the food preparers are doing all the things they should be doing with masks and gloves and so on. For cooked food, I'm a lot less worried about that because the virus won't survive with cooked food. But if you look at where the data shows that people get infected, they're out in the community. They're exposed to other individuals, and they're not wearing protection, and that's how the vast majority of people are getting sick with COVID, and there's a lesson there. So if you want to reduce your risk, then I would stay away from public eating facilities.
A couple of little individual quick questions. Someone's asked us your understanding of the risk of COVID if you're swimming. If you go to an outdoor pool or an indoor pool. Obviously, an indoor pool has more risk because you're in a gym with other people, but the actual process of swimming.
So I don't think there's much of a risk at all. If somebody with COVID was swimming in the pool right before me, let's assume that they're asymptomatic, then I would say that my risk of getting COVID from going in the pool after they got out is very, very low. It's zero. I think for people who are concerned about, I'd be much more concerned about what's going on in the locker room. Standing next to somebody at a sink and shaving, and they're next to you. That's a much, much higher risk than being in the pool. So I don't see the pool necessarily as a high risk adventure. It's what happens when you get out of the pool. And I think that's where the risks are.
And can you reassure, again, we have several questions, can you reassure people about the simple risk of being out in public when you have somebody walking by you, the postman goes by you, or just another citizen walking by you, you may be 4 feet apart, but the risk of just catching it by literally passing nearby somebody or a truck or a worker being near you. How aggressive you need to be to avoid every single person?
Right. I would say outdoors, the risk is very small. We have a great volume of air out there, obviously, and the wind currents and so on and so forth. I mean, if you're concerned about it, you can wear a mask. But I would say that the risk is quite low. And where we see these outbreaks of COVID, where we see people getting infected with COVID, are people who have been in a closed area with an infected individual. So these big gatherings at barbecues, for example, there are outbreaks that have been documented in churches where an choir practice. So these are all situations where there's a lot of close contact. Now we're seeing it in the dormitories, sorority houses, for example. So this is where your biggest risk is. I think walking down the street and having a few people pass you, I think the risk is very, very low. And I mean, I think nowadays, I mean, we're all getting a little stir crazy with this pandemic for sure. To go out and get some fresh air and take a walk. And I think that's a very safe activity.
And can you give us your opinion on currently the status of airports and flights? Has that changed at all? Any more willing to take that risk, or is it still the same concerns?
I think it's the same concern. I think that the airlines have gotten very good about requiring masks for everybody. What many people may not know is that the air in an airline is actually circulated through HEPA filters. So actually the air quality is quite good. And we know this because of outbreaks of other infectious diseases that have occurred on airplanes. Typically the risk is just the people sitting around you, the row behind you, row in front of you, and next to you. If there's somebody 20 rows up there who's got COVID and coughing, and you're in the back of the plane, the air circulation is filtered, so there the risk is probably low. But on the other hand, you're going to an airport, there are a lot of people there, you don't know where these people have been. Obviously, some of them may be coming from high incidence areas, some maybe low incidence areas. You don't know what practices they had outside of the airport. And yes, wearing a mask reduces the risk, but it doesn't reduce it to zero. So I would say that you have to be very, very careful if you're thinking about flying. And certainly if you fall into one of the high-risk groups.
We're getting near an hour. We have 2 more questions to go, and maybe a few final words. But one thing I omitted I forgot to ask you when we were talking about the vaccine. Are there any other things besides vaccine that we should consider seriously? We hear about using plasma of people who've been positive in the past. Are there any other things besides vaccine that may have some hope in providing some treatment, if not prevention?
Right. I mean, I think the ideal approach right now would be to have a medicine that can be used to treat COVID and to use as prophylaxis. So let's take a step back. Let's look at influenza. We talked a lot about vaccines, but there's a drug, Tamiflu, very, very effective in inhibiting influenza. And it can be given to somebody who's sick, or it can be given to a household contact of somebody who's sick to prevent them from getting sick. And it's very, very effective. And I actually think that we may actually have a therapy before you have a vaccine, because a therapy is much easier to study. We could just identify a group of sick individuals and give them the therapy, and of course give another group a placebo and compare them. They're here. We don't have to wait for them to get infected. So I think there's a lot of promise on developing potential therapies. Obviously, therapies have to be very practical. There's a drug right now which we're using for sick patients called remdesivir, but that can only be given through intravenous line, and that's obviously not practical for the very large percentage of the population that doesn't end up in the hospital. So if we can get to a therapy that could also be used as a prophylactic agent, that would really bridge us to a vaccine. And there are a number of compounds that are being looked at right now that actually have been studied for other diseases that may be effective. There was a lot of hype about hydrochloroquine, for example, hydroxychloroquine, I should say. That didn't pan out based on the studies. But there may be other drugs that are readily available that may be effective. And to me, I think that's what's being lost in a lot of the vaccine talk, is that can we develop some compounds that can be taken orally and used? This convalescent plasma story, again, taking plasma from somebody who's recovered and giving it to somebody who's sick, it's really quite limited and really not practical for the most of the population. So I wouldn't get too excited about convalescent plasma.
We have one final question someone asked. I thought it was a very interesting question. With the high holidays coming up, it's obviously going to be very different for all of us. We won't be in shul, we'll be at home. And that's going to be a unique experience. And a big part of the holidays is eating together. And if someone elects to have some family over, but seating outside, distancing, doing everything they possibly can, there's still a concern that, yes, I've been safe, I've been cautious, I haven't been eating out, I haven't been doing anything, but my guests haven't been as cautious as I have. They've been traveling a little bit, and so what's your recommendation for, and that's an awkward situation to be in, I don't want you near me, or what's your recommendation for not only the risk, but deciding how to handle that when you're going to be cautious, but the people around you, you know, maybe not quite as strict as you have been.
Right. So I think the first step in that, and by the way, this comes up on a variety of different levels. This is a topic that came up during the summer about having kids have play dates, right? You know,
Sure.
You're mixing your kid with some other family's kid. How are you going to approach that? So I would say the first thing is to be perfectly transparent with one another. And this is not a judgment on their character. Just say, tell us what you've been doing. And if somebody says, well, I traveled a little bit and I know I was on a plane last week. Well, yeah, maybe that's not the person you want to be breaking bread with. On the other hand, you know, you could be very smart about this. If you're outside and you're socially distanced, you know, if everybody brings their own food, or you have disposable utensils, or not everybody's grabbing the same spoon and fork to serve the food. You know, just make sure that there's no mixing and mingling of utensils, of glassware, of course, and plates. That may be very effective. You know, everybody bring their own food, like a potluck dinner, I suppose. But remember that you know, there's always an inherent risk. The risk may be low, but there's an inherent risk to that, and it's up to everybody to decide what level of risk they want to take. So this is different for everybody on this call. Is going to have a different approach and opinion on this, and you know, if you want to play it safe, you know the answer. On the other hand, you know, we're all craving to be social. You know, we're going to be sitting looking at a computer screen for the high holidays. Who would have thought that 8 months ago? But this is the new reality, and you know, we have to accept it and not be blind to the potential consequences of gatherings.
Well, Jeff, I think our time is just about up. Do you have any final words? Anything I didn't get to ask you, or other people didn't get to ask you, that you want to tell our seniors specifically about, you know, what they should be looking forward to or dealing with that maybe we haven't covered?
Yeah. So again, emphasizing getting the flu shot. That's the one action item that everybody can do here. You know, I think we have to keep our eye on the ball. There's a lot of new developments here, and you know, a lot of conversations about vaccine. And Mark, as you mentioned, there's a lot of chatter out there, but there's really not a lot of substance right now. So, you know, maybe we can readdress this in a few months as we get a little bit more information about these vaccines. But, you know, be careful, be smart. And, you know, this is obviously an extraordinary situation, and it's a heavy weight on all of us. And, you know, be safe.
Well, I know once we do have an actual vaccine, I know Phil will be all over it, having another meeting and having you back, and that will be wonderful because you'll be able to answer a lot more questions that we're asked that at this point we simply can't.
Right.
Jeff, thank you so much for your time and your presentation and the efforts you've given. I know you've answered a lot of questions for people. There'll always be more questions, but I'm sure we'll do this again. Thank you very much.
I'd be happy to do it again.
And thank you, Mark. Thank you, Dr. Kahn. It was great.
All right.
Thank you, guys.
Thank you.
Thank
Good night,
everybody for coming.
Everybody
Very
be
much
safe.
appreciated.
Thanks, everybody, for the planning.
Thank you.